A copy of the PowerPoint slides will also be available on the website under toolkits and resources. Our presenters will stop and ask for questions at several points during the presentation, and there'll also be time at the end. If you have a question or a comment, please type into the question box during the presentation, and we'll read out your question or unmute your line. If you receive, at the end, you'll receive a brief survey. We appreciate any of your feedback. It helps us improve for future presentations. So today, for our distinguished speakers, we have Dr. Leena Mittal, who is a board certified in psychiatry, psychosomatic medicine, and addiction medicine. Her clinical and academic interests include collaborative care for complex perinatal patients with mental health and substance use needs, including integrated treatment for pregnant and postpartum women with opioid use disorder in the perinatal care setting. She's the director of the Women's Health Mental Health Division, the Department of Psychiatry at Brigham and Women's Hospital, and an instructor at the Harvard Medical School. Our other distinguished guest is Dr. Nancy Byatt, who is a psychiatrist, physician scientist, and perinatal mental health expert who is focused on improving healthcare systems to promote maternal and mental health. She is the director of Women's Mental Health Division, the Department of Psychiatry at UMass, and Associate Professor of Psychiatry, OBGYN, and Quantitative Health Sciences at UMass Medical School. She's also the Executive Director of Lifeline for Moms. So I will let these two lovely women take over.
Thank you, Beth, for the introduction, and Sarah, thank you for advancing the slides. Neither Nancy or I have any conflicts of interest, financial disclosures to make. Next slide. And I always think it's important to kind of level set a little bit and talk a bit about trauma. So we're here to talk about trauma-informed care in perinatal settings and how we can think about including trauma as part of the set of considerations, or potential trauma exposures as a set of considerations when we're engaging with patients. So this is a definition accepted by SAMHSA, which is the Substance Use and Mental Health Services Administration. Trauma is defined as an event, series of events, or a set of circumstances that is experienced by an individual as physically or emotionally harmful or threatening, and that has lasting adverse effects on the individual's functioning and physical, social, emotional, or spiritual well-being. And I think it's important then to take a step back, and I always sort of think to myself, trauma is in the eye of the beholder. And so if an event or series of events is perceived as traumatic, then that is ultimately where we have to sort of accept that that's how it felt, and how the person has moved forward with that history in mind. Next slide. Trauma is also extremely widespread. The majority of individuals, in one study, 50 to 90%, have had exposure to some kind of traumatic event in their life. Interpersonal violence is more common, especially in the context of pregnancy. This is a sort of common board question for all of us in psychiatry. This is asked. One of the sort of sad truths is that in pregnancy, women are more at risk for interpersonal violence, and that makes it in fact more common than gestational diabetes in terms of a complication or exposure during pregnancy. Next slide. And it's also can be quite striking to think about that maternal trauma, or trauma experienced in the course of pregnancy, can negatively impact the pregnancy itself, the postpartum experience, and as well as the well-being of the infant. Trauma can be associated with exacerbation of perinatal mood and anxiety disorders. It can impact maternal-infant bonding. It can result in alterations in the course of breastfeeding. It can increase risk for preterm birth, lower birth weight, and also for the baby, dysregulation in fetal neurobiological systems. So, for example, kind of this regulation, beat-to-beat variability, startle, things like that, for fetus, and then also can be seen in infants as well. Next slide. And, you know, I think there's also this kind of discussion about adverse childhood experiences and trauma and how they overlap. Adverse childhood experiences were originally defined in the context of a large study about 20 years ago, almost, that occurred through the Kaiser system, large primary care system in California. And essentially, it was a system of sort of counting the number of adverse experiences that someone has experienced in their history, and then that number, that as you count, each number sort of gets weighted into a total score. And the higher the number, essentially, the higher the pervasiveness of medical health and well-being, as well as mental health and well-being. But what are adverse childhood experiences? And I think this image of ACEs as a tree, really it describes kind of the soil and the air that the tree is cultivated in. So the soil is thinking about what's the community environment that somebody is coming from, what are the contextual and community and sort of the earth from which the person is growing, the tree is growing. So poverty, discrimination and racism, community disruption and community violence, economic mobility, decrease in sort of financial stability and lack of opportunity, poor housing. All of these are sort of just examples, not comprehensive, but of examples of community ACE exposures. And then beyond that are sort of the individual level experiences: domestic violence, homelessness, incarceration, mental illness, divorce within the home, physical neglect or abuse, emotional or sexual abuse, maternal depression or having a depressed caregiver, substance use in the home, substance use in the individual. All of these individual experiences that get layered on the sort of soil, so to speak, that the tree is growing from. Next slide. And in women, trauma and adverse childhood experiences are associated with increased rates of substance use disorders, increased rates of self-harm and suicide attempts, earlier pregnancy, so pregnancy and adolescence, fetal death, and medical comorbidities. And the medical comorbidities are pervasive across all systems, all organ systems, and the list is just sort of too long to go into. Next slide. And then when we think about some of our sort of the confluence of risk and factors that we can be thinking about, you know, one of the populations that we see significantly higher exposures to trauma and violence are in women who are pregnant and then also struggling with substance use disorders. And so in this study, for example, women with opioid use disorder who are engaged in treatment for OUD had an average ACE score of 4 or more. And to contextualize that, in the general population, the typical average score is 1.4, and in this population it was 4.3. And 16 to 26% of pregnant women with OUD are diagnosed with postpartum or with PTSD as well concurrently. And PTSD also then is more commonly associated with other mood and anxiety disorders. And so you can see that trauma and other comorbidity can track together significantly. Next slide. Pregnant women with opioid use disorder are twice as likely to have a mood disorder as they are if they have PTSD as well. Patients with borderline personality disorder are twice as likely to develop PTSD, and borderline personality disorder has been conceptualized in a variety of ways, including as related to traumatic exposure. Anxiety and depression themselves are comorbid with PTSD, so it's sort of bi-directional, kind of goes both ways. Next slide. And those are all for not just in pregnancy, but outside of pregnancy. Thinking about sort of trauma and stress-related disorders, and you know, how you go from a traumatic exposure, how we sort of contextually categorize the outcome or the sort of symptomatology. There are a lot of different combinations of symptoms that can occur, and trauma and stress related disorders sort of occur, and there's a cluster of them, a group of them that we think about, and a lot of it is the time from which the symptoms emerge in relation to the traumatic exposure itself. So we have acute stress disorder where the symptoms may emerge in the immediate aftermath of a traumatic exposure. PTSD is after a month, and then delayed onset would be if the symptoms have onset 6 months after the stressor. And then there's also a categorization for chronic PTSD where the symptoms persist beyond the stressor beyond 6 months. The categories of symptoms for PTSD, and this is really when traumatic exposure results in symptoms that then rise to clinical significance. We categorize the symptoms in different ways. Intrusion symptoms, which can be flashbacks, for example, having kind of sudden out of nowhere in a way, intrusion of intense re-experiencing of the event. Avoidance symptoms can come in a variety of ways. They can be sort of agoraphobic, where somebody doesn't leave, or somebody may avoid certain areas, a whole variety of different forms of avoidance that can come after a traumatic exposure. Negative alterations in cognitions and mood. So people who have had traumatic exposures have a really significant alteration in the way they see themselves, the way they see the world, and then also persistent low mood that may not necessarily qualify separately for a distinct mood disorder, but sometimes does. And then alterations in arousal and reactivity. So sleep disturbance and nightmares, having increased startle response, jumpiness, quick to anger, those sorts of sort of level alterations in arousal and reactivity, sort of emotional affective dysregulation can go in that category as well. Next slide. One of the things that's most important to recognize, though, is that there's no one way that PTSD always presents. And in fact, a colleague of mine calculated there are greater than 636,000 ways, if you have all of the combinations of the potential symptoms, to meet criteria for PTSD. And so what's most important, and this is actually true for all psychiatric diagnoses, is that it's important to take a step back and say, what is the functional impact? To what degree are these symptoms burdensome and impact the functioning that the person wishes to achieve or the roles that they are in? Next slide. The other side also of trauma and traumatic exposures is also this notion of post-traumatic growth. So we talk about post-traumatic stress, and we talk about the sort of the pathology that may emerge, the clinical disorders that we can define, but there is also this opportunity presented that we see in people who have had traumatic exposures, where there's this potential for growth and for resilience to emerge. And resilience is, in some ways, there's still some debate about the degree to which it's state versus trait. Is this something that somebody has inherently, or it can be fostered or developed? High levels of resilience can help mitigate the consequences of a traumatic exposure. Low kind of resilience scores or low resilience characteristics are associated with increased impact of the traumatic exposure. Those with high resilience have lower rates of postpartum depression and lower rates of developing frank PTSD, higher rates of self-efficacy and perception of competence and capacity to manage stress. And one of the things that's thought to contribute to developing or supporting the emergence of resilience or existing resilience is supportive relationships. So thinking about support, and while that's something that we can't always infuse into a traumatic or stressful situation, it's something to think about in terms of, are there ways we can enhance that? Next slide. And to transition a bit from what is trauma and what are the sort of clinical significance, clinically significant things that can emerge from traumatic exposures, it's important to think about the fact that trauma itself, having had any kind of traumatic exposure, can impact healthcare, and it can be bidirectional. So a history of adverse childhood experiences can be associated with a multitude of health problems, as we've already discussed. Healthcare itself can also be the services that are delivered and the experiences that people have in the context of seeking healthcare and and getting care can be traumatizing or re-traumatizing. And that's based on a variety of sort of historical contexts along with individual level experiences. And prior trauma can significantly influence how the healthcare system is engaged with. So if somebody has had prior experiences of health-related trauma or trauma in their life, it will change the way they engage with other types of help and healthcare. Next slide. And this can happen in a variety of ways. So within healthcare, there are interpersonal factors. We cannot deny that there are power dynamics between healthcare systems and healthcare providers and patients who may feel very dependent or uncertain about how things may go. Sometimes a gender, the gender of the patient and the gender of the provider, the interplay there can contribute to an experience feeling potentially traumatizing or in fact feeling traumatizing. And then seeking healthcare requires sort of a disclosure and some alterations in privacy. So the provider is asking questions that can feel intrusive, and the patient has to disclose things. And also there's physical issues in terms of disrobing or examinations and things like that that can be that can contribute to the way in which healthcare experiences can be traumatizing or re-traumatizing. And the sort of the feeling of being exposed, the physical discomfort that can come from an examination, the positions that someone may have to be in order to get the healthcare, whether it's related to a procedure or to an examination, and even just simply being touched can, for some people, depending on the histories that they've experienced and the feelings that are attached to those histories, can be re-traumatizing. Next slide. So, and in obstetric settings, trauma and PTSD can go unnoticed. I mean, there are times when we become, as providers, very aware, and in obstetric settings, patients may feel comfortable disclosing, or it may be part of the chart already, but there are times where we don't know what it's like, what the person is experiencing. Patients may not be comfortable disclosing spontaneously because they feel shame, because they feel helpless, because they feel that they'll be judged. Or if the part of the traumatic exposure is related to somebody who's with them or who's currently in their lives, there may be concern about the implications for disclosing outside of the office. And they may carry fear about subsequent involvement for Child Protective Services. Providers, as with many mental health conditions, I think it can be concerning to say, well, am I an expert in this? What if she says, yes, this has happened, or this is happening now? What am I going to do about it? I'm not sure. Do I have enough time? Do I have the resources that will help me respond to this appropriately? And so we sort of all can get, for different reasons, kind of continue to operate not fully knowing what's going on, or the traumatic exposures. Next slide. And so in comes trauma-informed care. And there are sort of 6 guiding principles related to trauma-informed care that we sort of take as sort of the grounding for how we approach implementing care that assumes that people are all coming into healthcare settings and into whether it be as the providers in the workplace or patients seeking healthcare with trauma histories, and that we can sort of go forward implementing care that takes into account the potential that any one of us could be experiencing or re-experiencing trauma. Safety is at the top. And if we go around in terms of the circle, trustworthiness and transparency comes next. And so being able to develop a sense of trust and to have transparent conversations, and that can be expressed in a variety of ways. It can be in the way a clinic operates. It can be in the way the one-to-one interaction goes, where there's open conversation, and all aspects of care, the rationale for things that are happening can all be very transparent. That's one sort of example of how this principle can be implemented. Peer support is considered a core of trauma-informed care. So valuing sort of the lived experience and having opportunities to engage peer support whenever able. Collaboration and mutuality is, and these are all intertwined too. Collaboration and mutuality is sort of taking that healthcare is delivered as part of a team, and that members of the team all exist in a lateral relationship where there is a mutual sharing of opinions, of ideas, and of decision making. Empowerment, voice, and choice is another sort of is closely connected to that, where the patient herself or himself and all the members of the team feel that their voices are valued and are part of care, the construction of care delivery, as well as the direct care that's happening. And then again, sort of back to the tree, the tree as the analogy, the context from which we all come adds to trauma that people may experience. And so there's a long context of cultural, historical, gender, structural, racial trauma, and acknowledgement of those histories is embedded in sort of the core of trauma-informed care. Next slide. And when thinking about kind of what that means for the paradigm of patient and provider, it's really taking this shift. This is I credited a colleague of mine who is core to the trauma-informed care efforts within the MGB system, and this paradigm shift that she describes as sort of going from what's wrong with you, this kind of pathologized, punitive, sort of blaming, reactive stance, to what happened to you. And then really the next question is, and how can I help? And so it's really this kind of shift in paradigm from the pathology to we're in this together and we're all managing a reaction to a set of contexts and experiences. Next slide. And the sort of final piece about how trauma-informed care can really be framed is that we really should be thinking about this in the same way as we do infection control now more than ever, universal precautions. So trauma-informed care should be applied universally in a healthcare setting so that you're not necessarily waiting to be aware that somebody has a trauma history and so therefore we should operate with special care, but that the whole system, the whole context that the care is happening in is taking into account that everybody involved may have experienced some trauma or may be potentially traumatized by what's going on. And so if we're applying these principles universally, then we're being mindful of where everybody is coming from. And at this point, I'm going to hand this over to Nancy to talk a little more about the specifics about how to implement trauma-informed care. Thanks.
Thank you, Leena, for that wonderful first half of this. So as Leena said, the part of the core principles is that this is applied universally. I think sometimes people think of this as, oh, we're going to screen for PTSD and talk about this if it's PTSD. It's really meant to be universal. And as Leena described, really thinking that, you know, for example, there's no wrong door, and also with understanding that everyone has experienced adversity in some way, but also acknowledging that certain people and populations have experienced more adversity, and really acknowledging that as part of the care and being interested and curious about that, and going about that in using a strength-based approach. So to give some examples here. So utilizing some of the principles. So the environment, that it's calm and clean, that there's privacy, you're respecting women. It's important. Women are going to be respected when their privacy is respected, that it's accessible, and that it's pleasant. And then for policies, there's no wrong doors. There's no wrong way to get in somewhere. And this again gets back to this, you know, for example, if someone's late to an appointment, it's not like, why are you late? But like, you must have had a good reason for being late. You know, it's good that you're here and asking them about why it was challenging to get there that day. And then also having clear and transparent policies, language accessibility, and also asking for feedback, wanting patients' feedback about how the services are provided, and proactively seeking that and having a can-do approach. Also, in regards to attitude beliefs, having it be patient-centered, and asking questions, not making assumptions. So it goes back to the example of if someone's late for an appointment, not making assumptions about why they're late. And then also honoring differences in coping. Many people have many, many different ways of coping. And, you know, acknowledging that people acknowledging having the underlying thought being that people always have a good reason for doing what they do. It may not be what you would do or what maybe was taught to you in medical school or what we may have in the past referred to as compliant, but, you know, people have different ways of doing things, and to understand that and honor those differences. Yes, next slide, thank you. So also when we think about implementation. So a trauma-informed organization. So all of you working in, a lot of you, I recognize some names are from obstetric practices. So what do you do to make your practice trauma-informed? So one, it's realizing that trauma is prevalent and widespread. So Leena gave some of the figures, and there's also, when we think about that, the data with opioid use disorders, it's likely even more common than that, because many people, I can't tell you how many women I see that they have meet the criteria for PTSD, it's never been diagnosed. So it's prevalent, it's widespread, and just because they don't have the diagnosis, they may have experienced trauma and not been they may have PTSD, not be diagnosed, and even without the diagnosis, there's a spectrum, and people can have trauma-related symptoms and also disorders. And also recognizing that trauma affects everyone in the system. So, our group actually just did a recent study looking at around birth trauma, which one of our medical students at UMass has been leading, and it was really learning about that the patients experience trauma, but also so do the providers. I mean, one provider in one of these studies said, it's like I'm going into a war zone every day when she was going to L&D. So, so recognizing that it's everybody. So the trauma-informed organization is thinking about this for patients and providers and for the whole system. And also thinking about this at all levels of operation. So you're honoring everybody's experience, again, at all levels in the system, patients, providers, staff, everyone involved and interacting with women and involved in the organization and the operation. Next slide, please. So when we think, so one way to do this, one obvious way to think about trauma and to make sure, it's like with depression. When people screen for depression, it facilitates the conversation and it makes it part of the culture and it makes it part of the workflow. So one way to do this when we think about trauma-informed care is screening not necessarily just for PTSD, but things, other adverse experiences and social determinants. So, and that can allow you as a practice to be proactively addressing risk factors, all those pieces in that tree that Leena described earlier, and then engaging patients in interventions that can be tailored to them and are culturally responsive. Next slide, please. So this is a summary of the ACOG committee opinions recommended screening for trauma, PTSD, and interpersonal violence. So for childhood traumatic experiences, the ACEs questionnaire, it's a 10-item self-report. And I won't go into the details that Leena already described. She made a very good case for why it's important to screen for ACEs. It impacts all of our patients' health outcomes and mental health. For PTSD, there's a PTSD screen. There is one. There's a civilian one and a veterans one. The PTSD is one that is validated for use in civilians. It's a 5-item screen designed for use in primary care. And then there's also a longer screen. So if you screen for one for PTSD and you wanted to get into ask more questions, there's a 20-item self-report as well that can be utilized if someone screens positive. That takes longer to fill out. But sometimes it's being recommended now, and actually ACOG just came out with a toolkit that's actually recommending screening with the PTSD along with screening for anxiety and depression in obstetric care settings. And that toolkit, if anyone's interested, is available on, it's available on the Life, if you email me, I can send it to you. It's available on the Lifeline for Moms website. So it has screening for depression, PTSD, and generalized anxiety. So for IPV, there's several screens available for IPV. There's the HARC, there's the HITS, and the woman abuse screening tool. One thing just to be, I'm sure all of you know this, but one thing that is really important to keep in mind, a lot of times when people think of interpersonal violence, they're thinking of something physical, and they're thinking of, a bruise, they're thinking of physical. A lot of times it's about control and manipulation and coercion. So women may never have been, physically hurt and can, one, meet the criteria for, PTSD, because it's not, there's many other experiences of trauma as Leena outlined. And then also they may be experiencing interpersonal violence without any physical trauma. Next slide, please. So how do you have these conversations? So we actually did a focus group study ages ago, and women, the providers told us, we asked them, are you suicidal, homicidal? We hope they say no to all of it because we don't know what to do. And then the one provider said, the patient just told me she's raped. What do I do? This is really hard. And a lot of you may not be trained in how to do this. And this is exactly why we're having this webinar, because we know that these conversations are difficult. And yet they're really, really important. So some of the things, one way to remember this is the 4 C's, and you could practice how to do this. So one thing that's really important is to be calm. Leena mentioned earlier, not not sort of reacting when you hear these things. And caring for the patient and also yourself, because you are all doing, you're all providing care that you may, there is certainly secondary trauma that can be experienced among providers. So it's important that you're all taking care of yourselves as providers and managing any secondary trauma that you may experience. And also letting the patient know that, it's the best thing they can do for themselves and their baby is to care for themselves. And that includes attending to, their past experiences and acknowledging them. Containing the interaction. So one thing that's also really important is to, I think people sometimes think, oh, I have to talk about, the history of trauma when they were 5 years old. It's important to contain it, because if you go into detail, that can actually sometimes be, there needs to be a way to contain whatever information is disclosed. And so you can ask about it without, going into great detail. That can be done in a separate setting when they're, for example, referred for therapy. And even therapy, that has to be managed very, very carefully. How much do you, manage the current symptoms versus going, back to their history? But that can be done in a, mental health setting. And then also focusing on coping strategies. So asking, for example, like what's one thing you can do for yourself today? And we will give later some concrete ways to be able to work on these things with women. But focusing on them as, and another example, if someone comes in and says, it's been so hard, I can't get out of bed, or I'm, thinking about the avoidance, like it's so hard for me to leave the house. So asking a question like, that sounds really challenging. How have you managed to cope? So it's a strength-based way of asking, asking them how they manage despite all the adversities they've experienced. Next slide, please. So other principles when asking about and gathering a history of trauma. So you want to be asking about this in private. That should, I'm sure that's implicit, but we want to say it explicitly. It needs to be in private. I can't tell you, sometimes these things do happen. So you don't want to be discussing mental health or trauma or any of this in a setting where there's other people. Utilize professional interpreters. This is really important. People do, it's really important, and also important that that person isn't a family member, that you want to have a professional interpreter used. And that's also a really important piece. And if they do endorse IPV, you want to affirm that it's not okay, that they deserve better, and that it's not okay for anyone to be treating them in a way in which they feel traumatized. And as Leena said, it's not about what we may think of as trauma, it's about how they experience it and honoring their experience. Offer warm handouts of support services, and they want to remain accessible to them. So telling them, I'm here, I'll see you back in X amount of time, and I'm here to help you, and we will continue to provide supports and be here for you. And then, I alluded to this earlier, when you're talking about past trauma, you don't want to get a detailed account of this. You can ask about it. You don't need to get into details. That can be done at a separate setting when that's determined whether that's appropriate and going to be therapeutic for the particular situation. You do want to inquire about, as I mentioned earlier, the current coping management strategies, and also engage them in the longer term trauma focused work. This is, often is long-term work. It does take an extraordinary amount of energy, and as Leena had mentioned earlier, resilience on the part of the patient, but really engaging them in that process as much as you can. Next slide, please. So what are the things that you can refer to? So psychotherapy is an evidence-based treatment for a lot of the things that you're all seeing: depression, anxiety, and also for PTSD. So CBT is an evidence-based treatment, also EMDR. As far as, what you'll likely be doing is, referring to us, and we MCPAP for moms, if you're calling us around this, one of our goals is always tailoring the therapy as much as we can. We know that it's limited with availability, so sometimes that's hard to do, but we always are working to do our best to tailor to the patient specific situation. So pharmacotherapy. So SSRIs are, generally considered the first line treatment option for depression and anxiety, and PTSD is an anxiety related disorder. So they're also considered for pharmacotherapy a first line treatment option pharmacotherapy treatment option for PTSD. The other thing that can often be used is second generation antipsychotics for targeted symptoms. So the reason we're describing this here is that if you see a patient that has PTSD and perhaps, comorbid depression is on antipsychotic, doesn't necessarily mean they have a history of a psychotic illness. It doesn't necessarily mean they have bipolar disorder. What it may mean is that they're experiencing anger, impulsivity, nightmares that aren't being managed well enough with a SSRI or an antidepressant in general. And so that's when often antipsychotics are used. And so that's just something to be aware of. We're not expecting you to necessarily be prescribing those, although, you might be in some cases, but if you see that, it's just so you're aware of that. And obviously, if you are thinking that, we're happy to speak with you at MCPAP for Moms, as always, about those things. Mother-infant diet interventions, those are often more difficult to access, but they are available. And we do have some of those in our database, but again, they are certainly harder to access. And then referring for support for interpersonal violence as well is important. Next slide, please. And you're often likely working with, have resources for that in your practice. So trauma and informed system also proactively addresses the needs of providers. I'd alluded to earlier that, providers, can experience secondary trauma. And, I mentioned that our student did a study she did in-depth interviews with providers and also a survey. And what we learned was providers are experiencing substantial secondary trauma. And that was what they reported to us. So really important that as you think about your organizations, that you're creating a space for providers to reflect on those patient experiences. A lot of what we heard in this qualitative data that we obtained also was that providers found that there wasn't a space for that they felt like, that there wasn't a support system or a place for providers. They were sort of expected to move on and buck up and keep going. It doesn't work, right? It doesn't work for our patients. It doesn't work for ourselves either. So really important to be creating a space to reflect on patient experiences and engage in resiliency building. And also finding ways to protect against compassion fatigue and burnout, because this can be a key part of this as well. Next slide, please. And what does resilience in an organization look like? Because one of the things that we also learned from those focus group data is that providers wanted that, and the providers were clearly reporting that they wanted resources. So thinking about resources for staff well-being, having flexible policies. So for example, having mandatory huddles, voluntary huddles, I meant to say, and not having mandatory debriefings, and just having things be flexible. So sometimes, when things are rigid, people can feel infantilized, and it can feel very, very disrespectful to people. And that's in all parts of the organization. A lot of times organizations have flexible policies for the physicians, but not for other staff. So really thinking about doing this in a way that you can have a flexible policy. Having clear communication. So that is so important because, we actually we were testing actually with one of our studies, we were testing with beta testing a new toolkit we have with a practice in California. And this toolkit actually screens for PTSD. The one I was describing, it screens for PTSD and depression and also generalized anxiety. And when we did this beta implementation, the providers came back and they said, well, the provider who was leading it came back and said, well, it went great. We did the screening, but the providers were kind of annoyed that they didn't know because they kind of implemented screening. So that was a real learning process for her and for the practice to realize, okay, we need to be clearly communicating. And people really feel disrespected if that's not happening. I think in medicine, we're reactive, medical systems are reactive, we move really quickly and we often kind of do things, but clearly communicating, okay, we're changes to the workflow, any changes to the practice. And that's one thing that can be done and it isn't a super time consuming thing. Training and learning opportunities, so looking at, what are training and opportunities around resilience and provider wellness, and then having attention to team morale. So this is so how can we implement trauma-informed care now? So, and that's what we're gonna talk about a little bit more in, I'll touch on more in these next few slides. Next slide, please. So challenge. So this is one of the challenging, so the next few slides are going to have a challenge and then we'll talk about how to approach that. So I'm going to if we think about COVID-19, which has sort of reached, I think, a steady state, what I'm hearing from providers and and what both in MCPAP for moms and in other settings is that, you know, it's reached a steady state. It's less acute than it was, but it's still obviously having an impact. And so during the pandemic, we do know that there's an increased risk for women to experience birth as traumatic. So what are some of the risk factors for experiencing a traumatic birth? So anxiety prior to labor, also the absence of a birth partner or perceived lack of support during labor and delivery, or anxiety about not having, a lot of organizations are allowing birth partners, and that varies, but people are still concerned about that. And then also feelings of disconnection, helplessness, and isolation during labor and delivery. Next slide, please. So what can providers do? Remember that principles of trauma-informed care are really important. And I would say they're more important now. They've always been important, but they're even especially important now because of COVID. I mean, I hear consistently from providers that, you know, there's this, you know, I mentioned the data from our study, and then also people are like, well, they're just asking us for more and more and more for less and less and less. And even, you know, salaries at times during COVID have been cut, many things that you guys are all at the front line working really hard. And this can be really, it can be hard. So remembering that, you know, our usual ways of and when we think about patients, remembering that the usual ways of providing nonverbal reassurance are impeded. So there's a sort of a combination where you all may feel beleaguered due to all the things that are happening. And then also when we're talking to patients, we don't have those usual things, which also can increase that. We have masks, we have to do physical distancing. There's little stickers when you go into the practice about where to stand. Maybe there's a piece of glass up, and all those nonverbal reassurance, both to ourselves as colleagues, but also to patients, are difficult. One thing you can do around that is making direct eye contact, using clear supportive verbal communication, and attentive focused listening. And also wearing a photo ID or adding a smile to your mask to offset the loss of nonverbal feedback. So there is ways to do that. And also mixing telehealth visits with in-person visits. Clear as obstetric settings and obstetric providers, you clearly have to see your patients. And psychiatry, we can do a lot of this over telehealth, not the case for OBGYN. So, you know, that can be a helpful way to do it. So they have that interaction, and then when they see you, they know your face when you have the mask on. Next slide, please. And what can providers do? So describing in detail the process for telemedicine visits and for arriving at the hospital. One often thing that, you know, we know about decreasing anxiety, particularly in the context of a history of traumatic experience, is knowing what to expect. When people don't know what to expect, it can be very, very anxiety provoking. So explaining to people exactly how it's going to go, and also giving people as many choices as they can throughout the process as much as they can. Having patients identify backup plans if their support person is COVID positive or becomes symptomatic, and encouraging creative means of support, having a doula or a birth partner or a video chat. The more, also we're learning more and more that having other people in the women's support system, you know, in addition to the medical team, is really important. So widening and broadening her team. And reassuring that visitation policies have evolved, and they're including increased support. And I know that they are evolving, and a lot of organizations are allowing more, you know, people there now. So really being clear about that, and also letting them know if that could change, if there's a surge, letting people know about that, and being very, very clear and upfront about what those things are, and making sure that you're asking if they have questions. Next slide, please. And also discussing. So people often, especially in the very beginning of COVID, people really wanted to stay in, there was a lot of movement towards, you know, home births. So working with women, again, being flexible. You don't want to assume anything. You want to, you know, for example, saying, instead of being like, well, why would you want to do a home birth? It's safer in the hospital. I'm sure none of you would say that, but, you know, asking, well, you must have a good reason for wanting a home birth. Let's talk about, you know, what are the risks and benefits of that, and really like assuming they have a good reason and noting that, and also asking, what are your best hopes for home birth, or what are your best hopes for a birth in the hospital, and really framing it in that positive way. Next slide, please. So the other challenge is there's a concern that you know, all perinatal women are increased risk for mental health conditions. And I get that concern. I mean, the rates have gone up. We know the data that's coming out shows that rates of anxiety and depression are higher. And so what can you as providers at the front line do about that? So discuss, as I've mentioned, concerns about what are their concerns about this time period, identify sources of support, referring to mental health early and proactively, and also screening early. Screening could be really helpful, even if a woman doesn't meet the criteria for an illness. It can start the conversation, and so you let them know that you're there and you can offer that support. And also, and the good thing about psychiatry is we're all available through telemedicine visits. And actually, I have found personally, we're seeing this in MCPAP for Moms, that it increases access because we now don't have the logistical barriers of the bus or, getting a PT1 form filled out, because we can do it over video. And if people can't do video, we speak on the phone. Not everybody has a great bandwidth on their Wi-Fi. So often we're doing it over the phone, and most people can do a phone call. So, and so it really actually increases the accessibility and letting people know that these treatments are still available. Next slide, please. So other things to be aware of is signs of trauma. So if you're working with women and you're thinking about signs, you're wondering, do they have a history of PTSD or have they experienced trauma before? If someone's avoiding prenatal care, it's so easy to make assumptions about that. It's because of X, Y, and Z. Assume that it's because they've had an experience that makes it hard for them to come. Again, you must have had a good reason for not, for that, and asking and understanding that. You may also see unusual fear of needles, IVs, or medical procedures, extreme sensitivity, as Leena mentioned earlier, about bodily exposure, recalling when touched during exam. I actually once had a woman I worked with who had PTSD from her delivery, from the experience she had her delivery, and really struggled to get she had a history of cervical dysplasia and really struggled to get a pap smear. So that's like an example of some, she did eventually do it. It took a really intensive team approach to have her to a point where she could get that pap smear. So if you notice someone's recalling during exam, meeting where they're at and making sure that you're being sensitive to that. Next slide, please. And asking them about what you can do to make them more comfortable and feel safe. So screening, other things to think about is screening for safety and privacy during virtual visits. So for example, you don't want to assume that someone's in a house with no one around. So asking them, are you in a private space right now? And asking them if we're not in a private space, coming up with some sort of signal so they can let you know. If, for example, someone who's, their experience IPV from, comes in, so you can have a sign to not be asking them questions or repeating something if you're reflecting that person may hear. So asking them and establishing that in the beginning of virtual visits, that they're in a safe place, and establishing a way that if they need you to stop talking, or if they need having a signal for that, or if they're unsafe. Also, always it's important to optimize autonomy and choice when able. It could be little things, but the more you can give people choices, the more you're going to empower them. Asking permission prior to physical contact. Every time you do something, asking them, and narrating the steps to the procedures in advance, including what physical sensations that might be experienced. And as I mentioned, in the woman I described who had PTSD from her delivery, which was a vaginal delivery, that's an example where that's really, really important. That's an extreme example, but even people, this can happen there's a wide variation. It happens among a continuum. And obviously maximizing privacy whenever possible. Next slide, please. And I see there's a couple things in the chat. I think we're almost done with the slides and we'll get to those. So other things that, we talked about involving the woman in decisions, explain what emergency interventions may be necessary before the labor so it doesn't come as a surprise, minimize loud directive or commands, be aware of nonverbal communication. For example, sit when speaking to the patient rather than standing over them whenever possible. That could, that can sometimes, that can also be helpful. Next slide. So this is, again, about COVID-19. It's been more challenging, and we did, in acknowledging this, next slide, we've created a couple of resources for you. These are available on our website. So some of these things I described about helping women cope, you could cue back to that for a second, please, the other slide. Taking care of yourself during COVID-19. They can be downloaded from our website. There's also a self-care plan. So those are a couple things that you can download these. You can give them out to your patients. So these are things that can be helpful. And next slide. And then we also created, this is a provider handout that sort of summarizes some of the things that we're talking about today. This can also be downloaded free from our website. You could give this out to practices, to providers in your practice. Next slide, and I think we're just about at the end here. So want to acknowledge, Leena, for her, doing this talk together today, and also all of our MCPAP for Moms consulting psychiatrists who often, contribute to the content of these and are just obviously a very valuable part of the team, and also the whole MCPAP for Moms team. Their references. I see we have a lot of questions in the chat box, which is great, and we definitely have some time to talk about. So one of the questions, and Leena, please join back because we can both answer these. Thank you. So one example is, one question here is, can you give examples of how hospitals have provided space for providers to reflect and create resilience? Do you want to give any examples of that, Leena?
Sure. One thing that, for example, October is Pregnancy and Infant Loss Awareness Month, and there have been a variety of displays that hospital systems have created. Sometimes there's a remembrance ceremony. So at the Brigham, for example, we have a once yearly memorial service. This year is obviously different, but in which families who've experienced losses of pregnancy can come, and a lot of providers attend too, and it's often an opportunity for joining. So that's one example I can think of. And then also just throughout the month, I've been hearing about community and hospital-based opportunities for processing loss. There's also within hospitals, EAP and different faculty mental health programs that are developing, especially in the context of COVID. I've seen a lot of these kind of crop up. I don't know if you have other thoughts, Nancy, or if,
I think that's great. I think you summarized it really well. I see the next question. I'm going to summarize this. I was reading the question, which is such a good question while you're describing. So this next question is, I think, a really good one. It asks about the way to respond to patients, because we do see when women, when patients have a trauma history, they often can present with anger, acting out, and they can get kind of maligned sometimes by the staff, especially when you have affect dysregulation, which often can present with borderline personality disorder, because there's a huge thing there. And there's an article that's well known, they can be someone that can be very hard to be empathic with. And I think that's what this sort of question's getting at. And then, and the staff feel disrespected by them. So that's one of the questions here. And I'll just say a couple of things here. I think one thing that's really important here is to, if as much as you can, give them choices around things. And I think one of the other things that's important here is that if people are, you want to be setting boundaries in an empathic way. I think that's the way. You do have to set boundaries, because boundaries are really, really important. And one thing we know when people are experiencing and often testing boundaries, because a lot of times what's happening here is those boundaries are important. It's also important to do that in an empathic way. And one of the ways to do that can be asking, about, how was that, asking what their reasoning was for that. You must have had a good reason for coming and saying that, and kind of assuming that positive stance again. And but also setting a boundary along with that. So those are some of the things. Also having the team be consistent, so you don't have them talking to one, providing the other. If you can have the team be as safe as and be as consistent as possible, so they're getting the same message, because sometimes what happens is they're getting different messages from different people. So that's also something. So you're talking to them with a unified approach, and everyone's consistent in the way that they're doing that, because sometimes they hear different things from different people. Giving them choices, and then Leena, I'm sure you have a lot of other things to add, so please go ahead.
Yeah, I think the other thing that this question is kind of getting at is also like, what is the team dynamic that can get created when providers are seeing different sides of what's happening in these difficult interactions. And one of the things that I feel has been useful is really trying to foster the empathy, like overall. So trying to find ways to, in the conversations with one's colleagues who are being essentially, or feeling very maligned, or feeling very criticized, or feeling very maybe at risk in the context of an aggressive interaction, empathizing there, and then also finding ways to articulate and find empathy for the experience of the patient, and not having those things be pit against each other, but that all of those things are true. That, this is such a difficult situation because it's really difficult to provide care to someone who screams and yells or curses at you, but I also feel so concerned because this woman has been abused her entire life and had a really traumatic experience. You know, whatever those things are can both be true, and it doesn't have to be either or. So that's the other thing, is like, if somebody who has the ability, you know, within the team to kind of hold those things and foster empathy can help.
Those are great. Yeah, those are great. Great points, Leena. So the next question here is, could you discuss differences in care for patients with PTSD that come from isolated events, such as a single sexual assault, versus complex trauma, as in women who've been raised with, you know, sometimes people experience trauma. They have extensive trauma histories with multiple repeated traumatic events. Would you like to answer that, Leena?
Sure. Yeah, I think that, you know, when there's a discrete singular traumatic event, sometimes there are some interventions that can be, the sort of technical terms for them are, there's like EMDR, which is like an eye movement treatment. Is cognitive processing therapy, certain types of therapy that can be done when somebody sort of had a clear, discrete traumatic exposure. The reality is that as the traumatic exposures become more layered upon each other, then the PTSD itself is more complex and often requires lengthier treatment, more multimodal treatment. And so it really ends up being kind of individualized to that person based on the symptoms and the impact it's having.
Mm-hmm. And I think when it's more complex, you often see you see the personality, how it affects someone's person, like the affect dysregulation and those pieces too, which need to be managed. You tend to see that more often when it's been more chronic, chronic repeated traumatic events. So another question is, so what kind of peer resources are available for with trauma PTSD who do not have substance use disorders? How do we find them? So this is women can go on our website. Under the MCPAP for Moms website, there's a tab for mothers and families, and we do have support groups. And that some of them are peer-led support groups, and they can put in their zip code and look for a support group. And you can also, when you call us, if they're looking for peer supports, we can ask for that. Do you have other things to add, Leena? That's one concrete thing.
No, and I think there's also a fair amount of peer resource that's found through social media. So there are large groups developed around the experience of having a traumatic birth, things like that, that are sort of not necessarily groups, but online social media.
Yeah, and PSI, Postpartum Support National, is a wonderful resource, and they have groups specific for, they have like LGBT groups specific for LGBTQ+. They have groups specific for people of color. I mean, they have a lot of groups. They're also tailored for to meet specific populations' needs. So the PSI is also a great resource. Oh, go ahead, Beth.
I was just going to say, a lot of these groups, support groups, have also gone virtual themselves.
Yes.
Some are still meeting in person, but
there's lots of virtual support groups. Yeah, so it's not a barrier in that way. So the last question here, we have suggestions of ways that providers may have made attempts to increase rapport during telehealth psychiatry therapy visits. Lots of patients assume they won't like it. This is a great question. Do you want to answer this one, Leena?
Yeah, and a lot of telehealth is in part just kind of being there and being reassuring, and kind of the challenges are, like getting connected, getting comfortable with the platform. I find that even just kind of creating a space where you're able to make eye contact with I'm not always great at this, like knowing where to look, but looking at the camera and trying to make eye contact, trying to connect around even someone's surroundings, or in things that you are learning. For example, like yesterday I saw a patient, and she makes art, and I've never actually seen her artwork, and it happened to be behind her, so we were able to talk about that. There are new things that you can actually learn about each other in the context of the telehealth. So I found that that's a way to sort of increase the rapport and kind of add some humanness to it.
I agree. I'll just add a couple. I totally agree with everything Leena said. And I think, just other thing, I think also letting people know that you can actually see someone's face over telehealth, and you can't do that when you're in the OB office. So that may be one way to just, letting them know that there's that part of it. And also the other part is, we find certainly in MCPAP for Moms that if we offer the phone, not everybody wants to do telehealth, especially people with anxiety, which, PTSD causes anxiety symptoms. They may not feel comfortable in the video. They don't want to look at themselves. That may be a major barrier for people. So you can also let them know, offer the phone as a backup. You can give them a choice. And I think you want to encourage telehealth, but if they don't, ask them. If they say, I don't want to do telehealth, ask why. And if they don't feel comfortable, respect that they don't feel comfortable with video and offer the phone. That may be, lots of people don't feel comfortable on the video. So that's another way to think about it. So again, you're kind of being flexible and offering them choices and autonomy. So I know we're just at 1. So but thank you all for participating. And and thank you, Leena, and to the MCPAP for Moms team. And thank you.